Hello everyone, today subgroup 3 is going to present case for ophthalmology. General data, Mrs. X, 43 years old female, came to the clinic with chief complaint of worsening of vision on both eyes, not associated with any pain, redness and tearing. History of present illness, 43-year-old female came in with a chief complaint of worsening of vision on both eyes, not associated with any pain, tenderness, redness and tearing. She has been experiencing gradual progressive blurring of vision for both eyes since 5 years prior to consult. No consult have been done or any eye medications taken. She came to the clinic because she was desirous of cataract surgery. Past medical history, our patient was not on any medication. In past medical history, we would like to ask that patient undergone any previous eye surgery or any eye medications or had any eye trauma. This will help us to narrow down the diagnosis of patient's condition. Personal and social history. In personal and social history, it is important to ask if the patient is alcoholic, tobacco user, illegal drug user, risk for AIDS or other sexually transmitted diseases. And in occupation history, is there any exposure to potential toxin? Reason is to know any potential risk factor for ocular condition. Family history. Here we will ask if the patient has any family history or first degree relative with the following condition of ocular disorders or medical diseases including diabetes mellitus or hypertension. Reason is to know any hereditary condition that may be underlying cause of ocular condition. Then review of system. In general system, there was no fever, chill, malaise, myalgia, fatigue, nausea and vomiting. In skin system, there was no rash, color change, itching and visible lesion. In ophthalmology system, there was blurred vision noted. There was no pain, epiphora, redness and cataract. In neurology examination or system, there is no headache, dizziness, blackout, numbness, vertigo, orientation changes, no slurred speech, forgetfulness and mood changes. Summary of subjective data. Pertinent positive, 43-year-old female, worsening of vision on both eyes, gradual progressive blurring of vision for both eyes since 5 years. Pertinent negative includes no pain, redness and tearing, no eye medications taken. Additional question to ask the patient is, do you have any family history of any eye condition? Are you suffering from any other eye disease, that is myopia or hyperopia? Is there blurring of vision of the entire field of vision or only parts of it? Do you have any history of migraine? Do you have any other disease like diabetes or hypertension? Objective data will be carried forward by Ashmit.
Everyone. Now we'll start with objective data. First of all, we have physical examination. In this, visual acuity of both right and left eye are uncorrected 20 by 70 and 20 by 50 respectively. Pinhole 20 by 40 and 20 by 30. Extraocular movement is full in both the eyes. Pupil 2 to 3 millimeter, briskly reactive to light and no RAPD found in both the eyes. Gross examination, clear cornea, anterior chamber looks clear, lens appear clear in both the eyes. Finger tonometry, soft for both the eyes, and Goldman tonometry 15. And normal Goldman tonometry is from 12 to 22 mmHg. Fundoscopy, clear media, yellow orange disc, and cup to disc ratio is 0.8, which indicate glaucoma, with disc hemorrhage on the 5 o'clock position and peripapillary atrophy. AV ratio is 2 to 3 to 2 ratio 3, which is normal, no hemorrhage or exudate in right eye, and clear media, yellow orange disc, CDR 0.7, peripapillary atrophy, AV ratio 2 is to 3. Now, no hemorrhage or exudate are found in left eye. Next, objective finding. We will start with right eye. Ocular dexter. Visual acuity, the major visual acuity is 20 by 70. Pinhole acuity test 20 by 40 noted, improved slightly. The presence of extraocular movement is full. Pupillary findings. Pupil size is 2 to 3 millimeter, briskly reactive to light. Pupillary defect negative. Gross examination finding. Cornea, anterior chamber and lens looks clear. Finger tonometry noted soft. Fundoscopic, yellow orange disc, CDR ratio 0.8. Now, what are the pertinent positive and negative in right eye? So positives are visual acuity of 20/70, increase in with pinhole 20/40, pupillary finding 2 to 3 millimeter, Briskly reactive to light, extraocular movements are present, full, cornea, anterior chamber and lens appears are noted clear, finger tonometry noted soft, peripapillary atrophy is found, and disc hemorrhage on the 5 o'clock. And what are the negatives? No hemorrhage, no exudates, clear media, yellow orange disc, AV ratio 2:3, and no RAPD is found. Next, we will see objective findings of left eye, ocular sinister, visual acuity. The major visual acuity is 20/50. Pinhole acuity test 20/30 noted, improved slightly. The presence of extraocular movement is full. Pupillary finding. Pupil size is 2 to 3 millimeter. Briskly reactive to light. Pupillary defect no negative. Gross examination finding. Cornea, anterior chamber and lens looks clear. Finger tonometry noted soft. Fundoscopic, yellow orange disc, CDR ratio 0.7. Now, what are the pertinent positive and pertinent negative in left eye? So, positive are visual acuity of 20/50, increase with pinhole 20/30, pupillary finding 2 to 3 millimeter briskly reactive to light, extraocular movement are present full, cornea, anterior chamber and lens appear noted clear, finger tonometry noted soft. So, and now what are the negatives? Pertinent negative, no hemorrhage, no exudate, clear media, yellow orange disc, AV ratio 2:3, no RAPD was found. Next, in next, what are the other physical examination which can be added? Gonioscopy. It helps to view the angle between cornea and iris. Corneal pachymetry. Corneal thickness is important because it can mark an accurate reading of eye pressure. Confrontation of visual field to evaluate visual loss due to glaucoma and damage to visual pathway. Next, in SOAP algorithm, we have assessment. In this, first we will find our primary impression, which is primary open angle glaucoma. So why would we take primary angle glaucoma as our final impression, or initial impression? Because primary open angle glaucoma is a chronic progressive optic neuropathy of adult onset. Characteristic of given case that justify our diagnosis are retinal nerve fiber layering thinning, optic nerve head cupping, progressive visual field loss, absence of signs of secondary glaucoma or a non-glaucomatous causes for the optic neuropathy, normal intraocular pressure. Next. So now what are the rule in and rule out for the primary open angle glaucoma? Rule ins are age above 40, peripapillary atrophy, normal intraocular pressure, visual field loss, cup to disc ratio is more than 0.5, optic disc cupping, and there is no rule out present in POAG.
Differential diagnosis. Normal tension glaucoma. Normal tension glaucoma is characterized by open angles, glaucomatous optic discs, progressive visual field changes, and thinning nerve fiber layers in individuals with normal interocular pressures. Normal tension glaucoma, the rule-ins are visual field changes, peripapillary atrophy, the CDR is greater than should be greater than 0.5, the age is also greater than 40, there is normal IOP, whereas the rule-outs are there are no retinal hemorrhages. Next one is primary angle closure glaucoma. Primary angle closure glaucoma is defined as partial or complete closure of the anterior chamber angle which can lead to aqueous outflow obstruction and raised IOP. The rule-ins are visual field change, age above 40, optic disc hemorrhage, CDR above 0.5. The rule-outs are redness of eyes, pain in eyes, increased intraocular pressure. Third one, ocular hypertension. Ocular hypertension is when the pressure inside the eye or the intraocular pressure is higher than normal. The rule-ins would be ages above 40, the visual field changes, whereas the rule-outs are high intraocular pressure, papillary atrophy, optic disc changes, and elevated CDR. So now the main thing, or there's a discussion on the primary open angle glaucoma. Definition. Glaucoma is the term that is used to describe a group of conditions that have in common a chronic progressive optic neuropathy that results in characteristic morphological changes at the optic nerve head and in the retinal nerve fiber layer. Progressive retinal ganglion cell death and visual field loss are associated with these changes. Intraocular pressure is a key modifiable factor. Now, the pathophysiology, the process of glomerular damage and the relationship with IOP and other potential influences is still poorly understood. One or both of the following mechanisms may be involved. Firstly, direct mechanical damage to retinal nerve fibers at the optic nerve head. Second, ischemic damage, possibly due to compression of blood vessels supplying the optic nerve head. Common pathways of damage would be that the both mechanisms might lead to a reduction in exoplasmic flow, interference with the delivery of nutrients, or removal of metabolic products, deprivation of neuronal growth factors, oxidative injury, and the initiation of immune-mediated damage. Here is a flowchart basically summarizing the pathogenesis and clinical findings. As you could see, there are the risk factors, then there is genetic predisposition, there is steroid responsiveness, which could all lead to primary open angle glaucoma, which would then increase the ion influx and the NO in the retinal ganglion cells, leading to retinal ganglion cell injury, which could ultimately destroy or there would be leading to the glial cell proliferation, leading to optic nerve head remodeling. Then there would be the direct mechanical damage to optic nerve head, or there would be ischemic damage due to compression of blood vessels supplying the optic nerve, ultimately reducing the exoplasmic flow, reducing also the delivery of nutrients, deprivation of neuronal growth factors, oxidative injury, and inflation of immune mediated damage. This could all ultimately conclude or come to the point that there would be apoptosis of retinal ganglion cells, the RNFL thinning and glaucomatous cupping observed on the fundus examination, or there could be RNFL thinning and glaucomatous cupping observed on optic disc or peripapillary and RLFL imaging. This could all conclude or come to the point there would be progressive VF defects and which could ultimately lead to the end stage visual field loss with retinal retained small island of central vision. Now the treatment plan. So for the workups, we would be including perimetry, tonometry, which would be for IOP measurements, gonioscopy, visual field test, serial imaging, optic disc examination, and optic nerve assessment. The treatment would be laser trabeculoplasty, which is the first line, which with a selective laser trabeculoplasty is often as effective as medical monotherapy. Nextly, we would be prescribing prostaglandin analogs, beta blockers, alpha agonists, carbonic anhydrase inhibitors, which was focused on the lowering of the IOP. The prescription eye drops, oral medications, laser treatment, surgery, or a combination of any of these would be the other treatment options. Now, before commencing any medical therapy, any drug chosen should be prescribed in the lowest concentration consistent with the desired therapeutic effect and administered as infrequently as possible. Now, for the surgery, we will go for the trabeculectomy, which is basically the surgical procedure most commonly preferred for primary open-angle glaucoma. In recent years, the threshold for glaucoma drainage device implantation has been lowered to many surgeons. Non-penetrating surgery is utilized extensively in POAG or primary open-angle glaucoma by some specialists. The role of microinvasive glaucoma surgery is being investigated, but there are no long-term results available. Now, these are our references from which we took our material for the PPT. Thank you. That's all.